Menendez with White Plume. I certainly appreciate you spending some time with us this morning. A couple of housekeeping comments before we get started. We do have a large number of people on the line today, so I'm going to leave everybody in listen-only mode. But that doesn't mean that we can't make this as interactive as possible. So take a moment to familiarize yourself with the GoToWebinar control panel. You can download a copy of the slides in a PDF format under the handout section. There is a question section where you can ask questions as we go. I'll try to answer as many of those at the end as possible. We are recording the webinar today, so if you'd like a link to the recorded version for yourself or to share with any colleagues, feel free to let us know about that. We'll have some poll questions as we go to try to make that interactive as well. When you see those poll questions pop up, just pick whatever answer of the multiple choice questions is most applicable for you, and we'll try to share the results as we go as well. All right. The other thing that I would mention to you is we've got a very short 3-question survey about the webinar at the end. That feedback, I look at every single one of those. It's very helpful for me. So if you wouldn't mind taking 30 seconds to fill out the poll question at the survey at the end, I would greatly appreciate that. All right. Again, don't feel the need to wait till the end for questions. If you've got them, go ahead and put those in the questions panel, and I'll try to monitor that as we go. Okay, so what do I hope to accomplish over the next 45, 50 minutes? I'm going to spend a little bit of time giving you the 50,000-foot view that says, you know, what is happening. We're changing kind of out of this meaningful use era into the world of value-based reimbursement. What is Medicare doing? What is the government doing with this shift to QPP, to MIPS, to APM? What's happening? What's the overarching goal? Spend a little bit of time talking about that. Then we're going to spend a little bit of time talking about HCC coding. This may be brand new for some of you. Others of you may have dabbled in it or may have a great deal of expertise in HCC coding. So we're going to talk about what that is, why it's important, why that will be more important going forward, right? Why your diagnosis coding is going to be more important now than it ever has been before. And then we're going to show you how that overlaps with MIPS, right? What are the categories? What does that look like? But how does risk adjustment impact MIPS? It will impact your MIPS score going forward, and so we're going to talk about that. You can see some areas of impact as well, because that means diagnosis coding is changing again, right? We've come out of the change from ICD-9 to ICD-10. We've come out of that grace period where Medicare was allowing unspecified codes. Most people aren't seeing a lot of denials from unspecified codes, but we've kind of come out of that change, and now it's about to change again. I'm not talking about ICD-11, but what I'm really talking about is some of the risk adjustment methodologies that are coming down the road. So we're going to talk about that. I'll share some stories about how I've seen clients handle that in case that's helpful for you. And then, as always, I'll leave time for questions and answers at the end. So for those of you just joining us, welcome. Glad to have you. I'm going to launch our first poll question. So what you'll see on your screen, it comes up, it's just a multiple choice question, yes, no, not sure. Do you have any risk adjusted contracts with any of your commercial payers yet? Typically what we see is about 18–20% of groups across the country are doing that already today. So all you need to do is if you pick one of those and hit submit, it'll lock in your answer. So today we've got more people that don't have experience with that. About 70% right now do not have commercial risk adjusted contracts, and about 30% of you are not sure. So that'll be really good. So hopefully this will be a helpful point for you today. So what I'm going to do is I'll go ahead and close that poll, and we'll move on. But thanks for participating in the poll. Hopefully that's a fun part of the webinar for you. So what CMS is doing with QPP is they are trying to move us out of this volume-based reimbursement world and move us into a value-based reimbursement world, right? The shift from volume to value. And what they're trying to do is accomplish the triple aim of healthcare. You've probably heard this before, delivering better care at lower costs and a better patient experience. right? That's a lofty goal. And usually everybody can get on board with that from a big picture perspective. But when you start to get down into the details, that's where it becomes difficult, right? The devil's always in the details. How do you do that? And Medicare, the federal government cannot do that by themselves. So they try to involve patients. They have tried to engage patients through the Blue Button Initiative, sharing patient data, making patient portals part of meaningful use. They are really trying to increase patient engagement in hopes that they'll make better healthcare decisions, that they'll engage in wellness activities so that they can avoid a trip to the ER, right? But that's easier said than done. And they're also trying to engage providers, right, to engage in some of this risk sharing. And so what the payers are trying to do, not just Medicare, but the commercial payers as well, is they're trying to shift risk off of the payer onto the patient, off of the payer onto the provider, right? And here's how we've seen this happen so far, right? We've seen this in our own company health plan for our employees. Every year it seems like the payer comes back with higher premiums and higher deductibles, right? That's more financial burden on us as patients. You've probably seen this with your patients as well, where particularly we're still kind of in the first quarter of the year, patients are trying to meet that deductible. There, you hear different questions than you heard 5, 6, 7 years ago, and we expect that'll continue going forward. You also see this through some of the patient engagement activities, trying to get them engaged in the portal, engage in their healthcare decisions. But you also see it on the provider side, where the payers are shifting risk to the provider. That's what the QPP is all about, right? Now, QPP has 2 tracks, MIPS and APMs. Probably 90+% of practicing physicians will fall under MIPS, at least in the transition year for 2017. But what we see there is the government's trying to measure cost and quality. They're trying to measure cost and quality, and they have to do that in a risk-adjusted way. We're going to talk more about how they do that, but I want to make sure we set up this framework so that you see what is happening in the industry as we make the inevitable shift from volume-based reimbursement to value-based reimbursement. Now, the CMS does have a timeline as far as what they're trying to do in shifting the Medicare dollars from fee-for-service with no link to cost or no link to quality to a more outcomes-based reimbursement world. Right now, at the end of 2016, you can see the majority of Medicare payments, right, 70%, are still Category 1 or Category 2. But the stated goal of CMS is to move that so that by 2018, by the end of 2018, at least half of that will be in Category 3 and Category 4. Now, obviously, most of that will be in Category 3. There's not a lot of Category 4 out there right now. But this is the direction that CMS is trying to move the industry in. Will they achieve that goal? Will they be able to do it that quickly? Probably not. I'd be a little bit skeptical of that. But that's the trajectory, right? That's the intent. That's where we are trying to move, and that's where I want to engage our brains in thinking about how do we look at this on the provider side? How do we make sure that we're capturing the right data that we need in order to be successful in a value-based reimbursement world? How do we make sure that when the payers look at us, they see us as delivering high-quality outcomes in a cost-effective way, that we're not being measured unfairly? So that's what we're going to try to look at. All right. So let me take a quick look at MIPS. I'm sure most of you are pretty familiar with this, but when we look at MIPS, the majority of the score comes from, or all of the score comes from 4 different categories. Right. These are the new 4 categories that were introduced as part of MIPS. Now, you'll recognize many of these by their old names. So you have advancing care information. That's what used to be meaningful use. Improvement activities is the smallest category, and it is a new category. This is not something that existed in the previous framework. quality that was measured under PQRF measures and under the value-based modifier in the old world. And then cost obviously was a component of the value-based modifier as well. Now, what I would draw your attention to is, rather than kind of drilling down into the details of all four of these categories, what I would draw your attention to is that 60% of your score under MIPS is about cost and quality. Those are the two largest categories and will always make up the majority of the MIPS score. And even if you're not participating in MIPS, or you're not fully participating in MIPS in 2017, what I'd want you to pay attention to is the fact that this is what Medicare is trying to tell us. This is what they care about. This is what they're really paying attention to, is cost and quality as we make the transition to value-based reimbursement. And you can see that in the old world, right? This is a sample QR-UR report. Some of you may have seen this, may have accessed this in the past. The QR-UR report will continue to be published annually. But you can see what they're trying to do is measure an individual provider's performance, that's the red diamond, relative to his or her peers. Those are all of the blue diamonds. And they're comparing that on two measures, quality and cost. You're going to hear this refrain again and again because this is what Medicare cares about. And this is what the other payers care about as well, right? So Medicaid, Blue Cross, United, Aetna, everybody cares about cost and quality. And on the provider side, you want to make sure that you are in that upper right quadrant. Right? Nobody wants to be in the lower left quadrant where they are low quality and high cost provider. You know, right now all of this data is private, but where we're headed is that Medicare would ultimately like to publish this on the Physicians Compare website, again, to better engage patients so that they can make what the government sees as better decisions, right? But we have to make sure that we're being measured correctly on this spectrum. Right? It sounds so simple. Medicare wants to measure and pay based on quality and based on cost. That seems perfectly reasonable. But the pushback has always been from physicians, wait a minute, you don't understand, my patients are sicker than everybody else's. We see the sickest patients. And therefore, my outcomes may not be as good. Therefore, my costs may be higher. And CMS has heard that comment and agrees with it and says, okay, we will make these measures risk adjusted. But you've got to prove it. You've got to prove it with the data. So Medicare has a risk adjusted methodology that they have used and made adjustments to over the past 10 years. And that's what we're going to spend some of our time today talking about, right? Their risk-adjusted methodology is called HCC coding, hierarchical condition categories. They were originally created in 2004, and the purpose was for capitated Medicare Advantage plans. Right? Everybody knows what these are. Medicare Advantage plans would take on a subset of Medicare patients, and the CMS would pay the Medicare Advantage plan a capitated rate per patient, per member per month, flat rate. So the Medicare Advantage plan had an incentive to try to keep down patient spending and keep the patients out of the hospital. But the Medicare Advantage plans also understood, you know, part of that depends on what your patient population looks like. And so in order to prevent any cherry picking of patients, and in order to protect the Medicare Advantage plan to make it fair, they came up with this risk-adjusted methodology. So this HCC score is used to measure patient acuity. Okay, so the higher the patient's HCC score, the sicker the patient is. the sicker the patient, the more expensive that patient would be, right? That's risk-based adjustment. And so it's still used today for the risk adjustment under the Medicare Advantage plans, but it is CMS's preferred risk-adjusted methodology. They also use it under hospital value-based purchasing. They use it for the transfer payments under the Affordable Care Act exchange plans. Right? This was for, you'd have Blue Cross and United both offering plans, silver plans in a given area. They didn't know who was going to get the sickest patients and who was going to get the healthiest patients, and that's really not fair to Blue Cross if they got all the sick patients and United got all the healthy patients. So what they did was they set up these risk corridors that would measure what those patients look like, and then they would transfer money between the two to level that out, and they use HCC as that methodology. So when CMS gets involved with risk adjustment, HCC is the methodology that they use. You don't necessarily have to understand the mechanics of the transfer payments, but what I want you to see is this is what CMS uses whenever they have these things. Commercial payers are also using HCC codes for some of their risk-adjusted plans. Again, we see about 18% of practices across the country that have some familiarity with commercial risk-adjusted plans. They are typically larger multi-specialty groups in a large metropolitan area where the payer has come and approached them about entering into some sort of risk sharing. So if you haven't seen that yet, you probably will over the next 2, 3, 4 years. So here's how HCC coding works. Let me break it down a little bit for you, get into a little bit of math in the morning. There are two components to an HCC score. You've got the demographic component and the diagnosis component. So demographics plus diagnoses equals HCC. From a demographics perspective, this is pretty straightforward. Age, gender, eligibility status all factor into the demographic component. So the older you are, right, the higher your HCC score is. If you are dual eligible for Medicare and Medicaid, your HCC score will be higher, because we know typically people that are Medicaid eligible, people that are from a lower strata on the socioeconomic ladder, are more likely to have higher healthcare expenses and more likely to have more chronic conditions that are expensive to treat and manage. So there's the demographic component. Not much you can do about that. Your patients are who they are, but that's part of the score. The other part of the score is the diagnosis codes for the past 12 months. Okay, so you look at all of the diagnosis codes from the past 12 months for that particular patient, and that factors into the patient's score as well. Different diagnosis codes have different weights. Some have no weight at all. We'll talk a little bit about that. I'll show you some examples and maybe even some tools that you could use to find out what your patient's HCC scores look like if you're interested in that. So you put the two factors together and you come up with an HCC score, and that is used as a factor. So the average Medicare patient has an HCC score of 1.0. So you take that HCC score, multiply it times the average cost per beneficiary, and that gives you the projected Medicare cost for the next 12 months for a given patient or a given patient population. Right? The larger the sample size, the better predictive power of an HCC score. It does a great job in large patient populations. When you're looking at one individual patient, there are scenarios that come up that can make that too high or too low. The larger sample size, the better. And so what this means is the higher the HCC score, the sicker the patient. The sicker the patient, the higher projected Medicare expenses for that particular patient. Okay? Higher the score, the sicker the patient, the higher the expenses. That's how HCC scores, HCC coding works. So let me give you just a quick example that might be helpful. If you look at a patient who's a 76-year-old female who is dual eligible for Medicare and Medicaid, her demographic component just by itself is 593. Now, what you'll see is this is why your diagnosis coding matters. Because if you don't code any of those chronic conditions, Medicare thinks she's relatively healthy, right? She's not going to cost $9,000 over the next 12 months. It's probably only going to be closer to $5,300. But you can see what happens when you start to code some of those chronic conditions. Even if you just code diabetes without complications, you can see a significant increase in both the HCC score and the expected cost for that particular patient over the next 12 months. And when you really do a good job of capturing all of those chronic conditions, diabetes with complications and vascular disease and congestive heart failure, you can see the difference in projected cost for that patient is over $10,000 a year. And that's just on one patient. Think about what happens if you look at a patient panel of 2,000 patients. If you've made this mistake over and over and over again, right, the difference in expected cost for that patient population could be over $2 million. You can see there's a significant difference in the diagnosis coding, what's been captured, what's been documented, how we've gone through and done that work. So let me pause right there. I'm going to launch another poll question for us. This is our second poll question for today. And the question is really, are you monitoring HCC coding or HCC scores today? So three choices for you: yes, no, not sure. Pick the one that best applies to your organization. Looks like so far we've got a few groups that are monitoring HCC scores today. So about 25% of you are paying attention to that today. So very interesting to see that. Love to hear your input through the questions panel. If you've got a story that you want to share with the rest of the group about how you're doing that or why you're doing that, always interested to hear that and share with the rest of the audience on the call today. All right, so thanks for participating. I'll close the polling question and keep moving. So thanks for engaging in the poll question. That's fun for me. So when I talk to people about this, you know, there's always seems to be a gap between what the provider thinks their patients look like and what the payer thinks your patients look like. The provider, I know that my patients are overweight. I know that they're not as healthy as they'd like to be. And I know that they're sicker than the average patient. But when my payers look at that, they think my patients look pretty normal. How do I explain the gap between my reality and the payer's perception? The gap is, the difference is in what we code. In what we code. We know that only 25% of our the people on the webinar today are paying attention to HCC coding, right? And even if you're paying attention to it, there are probably some areas where you can improve. And for the rest of us, you know, we are supplying Medicare and the other payers with this data all day, every day, and it's beginning to be used for more than just fee-for-service reimbursement. Let me give you an example from a specialty group. Let's pretend I go back to my stick-figure animation here. Let's pretend we've got 3 identical patients who all need total knee replacements, right? It's the same CPT code, right? It's going to get paid the exact same way as long as I have a diagnosis code that makes it medically necessary, right? So for patient number 1, let's say that we code unspecified osteoarthritis of an unspecified knee. And the reason I'm using that unspecified code is, this particular doctor still writes down the old ICD-9 code, and somebody else tries to go and convert that to ICD-10, and they use an unspecified code because they don't have any more specific information, right? That may get the claim paid. That may get the claim paid, but the patient looks relatively healthy to the payer. All right, identical patient number 2. We're more specific on our primary diagnosis. Very good. Primary osteoarthritis of the left knee. And we also have a BMI greater than 40, so we coded morbid obesity, right? The more weight puts more stress on that joint. It's probably going to impact their recovery time, their PT. That patient, we're a bit closer in the gap between my reality and the payer's perspective on that patient's risk factors. Patient number 3, not only do we have the more specific primary diagnosis and morbid obesity, but we also have, this patient has type 2 diabetes with polyneuropathy, right? Now we are accurately portraying what that patient looks like, right? We've closed the gap between my reality and the payer's perception. And so you can see what happens to the HCC score across 3 identical patients. Very, very different. Patient number 3's HCC score is twice as high as patient number 1. And what that means is the adjusted expected cost over the next 12 months compared to the average Medicare beneficiary, there's a difference of over $6,600 between patient number 1 and patient number 3. Most people are not thinking about this today. They're not doing this today because you haven't had to. Under fee-for-service, the claims have been paid the same way regardless of how you're capturing this. And this will be something that changes as we make that shift from the volume-based reimbursement world, from traditional fee-for-service to the value-based world that's coming under QPP, right? Now, I know this is something that's easy to talk about. It's easy to think about when we're here together on a webinar. But when you start to think about talking to your providers about this, I borrowed this slide from a Blue Cross Blue Shield Medicare Advantage plan in Michigan because I thought it spoke so well, right, to the physician mindset in most groups. You don't understand. Look, I get paid for CPT codes. I don't, as long as I've got a diagnosis code that makes it medically necessary, I'm fine. Most people are not doing this today, and you don't want this to be an extra burden on your doctor's plates. Most of them feel burned out. The meaningful use era was very difficult on physicians, right? They feel like they're getting more and more distracted and occupying their time with things that are not directly related to patient care, and they're getting paid the same or less than they used to, right? That is a legitimate complaint from our physicians. And what our patients really need, our patients need our doctor's time and attention, right? That's what they want. That's what they need. So why is it important to make sure that we accurately capture and code these comorbidities? As we transition to the value-based world, we want those targets to be set correctly, right? If our patient population, we're not accurately reflecting patient acuity, right? They look healthier than they actually are. Our cost target is going to be very difficult to hit. Our quality measures are going to be very difficult to hit. Ultimately, Medicare wants to be able to publish this data and make it available, and nobody wants patients to be, or potential patients, to be Googling your doctor's name and to find the Physicians Compare website that says high cost, low quality, particularly if that's not true, right? We want to make sure that we're being fairly represented. Patients are going to ultimately have access to that data. The MIPS quality scores, the resource use scores under MIPS are risk adjusted. So we want to make sure that we're doing that correctly. And there are lots of devils in those details, right, that says how do patients are attributed to me, what if I'm a specialist. There are lots of questions about that, absolutely. We may be able to get into some of those at the Q&A time at the end. If you've got questions on that, I'll try to address those. Another place where it's important are risk-adjusted contracts with commercial payers. Right? Again, most of you don't have those yet, but they're probably coming, so we want to be able to prepare for that. And then the last one, and I think this has some significant value to it, is think about payer negotiation. Take the example of the total knee replacement that we looked at on the previous slide. If Blue Cross Blue Shield, it's contract renegotiation time, Blue Cross Blue Shield asks for a discount because you do a high volume of total knees for their insured patient population, right? They're asking for a volume discount. Wouldn't it be great to be able to come back to them and say, hold on, time out. For my total knee patients, their HCC score is 9% higher than my other commercial plans. That means these patients are sicker. They're more likely to have a post-surgical complication, right, that we have to manage. I can't give you a discount. I should be charging you a premium. The payers have access to this data. They are paying attention to these risk scores right now, and we need to level the playing field so that you're paying attention to that too. Now, yes, they have an advantage that they've got all the claims data from all of the different providers in the community, right? They have an advantage on that side, but we at least need to be paying attention to what the data that we have and the data that we are submitting on those claims. All right. So let me ask this, kind of in light of the difficulty of getting doctors to capture this information, because that's not what we've had to do in the past. I'm going to launch another poll question. And this one is, which of the following best describes the majority of your physicians? I know you probably have different people that are in different places, but it's asking about documentation and coding. They never document these comorbidities. They rarely document. They usually document, or they usually document and code, right? Most people, we don't have anybody yet who's in the never document, right? Most of the time, we're seeing most people are documenting these comorbidities, but about 20% of you say that your doctors are documenting and coding. I'll be interested to see if the people that are documenting and coding are the same ones that are paying attention to HCC coding. They may have provided some education for their physicians to make sure that they capture that type of data. So everybody says that their doctors are at least documenting some of this. Some of the time, about 70% of you say that they are usually documenting, and about 20% are usually documenting and coding. So again, thanks for participating in the poll question. I hope sharing some of that information with you is helpful. Now, I know this can all sound a bit overwhelming, right? When you start to think about MIPS, then you start to think about risk adjustment and how we're moving and what that looks like. But remember, under MIPS, you're being compared to your peers, right? So this is a scenario where you don't have to outrun the bear. You just have to outrun your peers, right? You probably know the old joke about two hikers in the woods. They come across a grizzly bear, and they immediately turn around and start running. And one friend stops and changes out of his hiking boots and puts on his running shoes. And his buddy looks at him and says, "You are crazy. What are you doing? You cannot outrun a grizzly bear." And of course the response was, "I don't have to outrun the bear. I just have to outrun you." Right? So under MIPS, remember, you don't have to be perfect at this. You don't have to be perfect. We just want to be moving in the right direction. We want to be thinking about this. We want to try to start capturing these where it makes sense for my organization. right? Share with you some information that's helpful, that I think helps give you kind of a picture of some of the most frequently used diagnosis codes that have HCC weight. These are the top 10 most frequently used by volume that have HCC weight. Some of those are, like one of the things that I draw your attention to is the top two are both obviously type 2 diabetes. But if you look at in the far right column, you'll notice there's a very significant difference in the weight between with and without complications. So you can see that E11.9 has a weight of 0.118, but type 2 diabetes with any complications, all of those right now have the same weight of 0.368. That may change in the future. Medicare makes adjustments to the HCC model as different diagnosis codes have different predictive power for future healthcare expenses. But just kind of give you a quick overview of here are the most common ICD-10 codes that have HCC weight to them. And obviously this can vary by specialty. So when we look across like our client base at what they're documenting, what they're coding, you can see that if you look at the average HCC weight per diagnosis, very, very high in specialties like oncology, nephrology, cardiology. And obviously it's going to be lower in other specialties like pediatrics and OBGYN, right? If your pediatricians are not going to have patients with HCC scores anywhere near what the oncologists are going to have, right? Oncologists are seeing patients that have a cancer diagnosis, right? And that's going to make their HCC score much higher. Patients are also going to be older typically, right? So don't think about this as we've got to have a certain HCC score. The goal is to make sure that we are accurately reflecting how sick my patients are. And I've got to have that documented, and I've got to have it coded too. If it's just in my documentation, the payer knows nothing about it, right? Let's drill down and look within a given specialty, right? So we're going to drill down within a specialty and look at 30 different practices. So we look at 30 different practices within the same specialty, so they should be seeing the same types of patients. And you can see if you look at maybe the top 2, top 3 practices, their average HCC, not per patient, but per diagnosis, 0.03, 0.02. And look at the bottom 3, 0.01, 0.008. Those are 3, 4 times less than the top 3 practices. So what does that mean? Does that mean that the practice 1, 2, and 3, their patients are 3, 4 times sicker than practice 28, 29, and 30? Maybe. Maybe it means that their patients are sicker, or maybe it means that they do a better job of documenting and coding those types of comorbidities. Let's get a little bit more granular, and let's look within a practice. So now I'm within a single specialty practice, operating in the same community, in the same 4 walls, in the same specialty. And again, you can see that those top individual physicians, in some cases, those top 3 are 10 times higher than the bottom 3. And we have to ask ourselves, if I look at this in the eyes of a payer, they would say, oh, well, it looks to me like doctors 1, 2, and 3, their patients are 10 times sicker than doctors 28, 29, and 30. We expect 28, 29, and 30, their costs to be only 10% of what doctors 1, 2, and 3, their costs are. And that's probably a bad assumption, right? Probably not right. But payers are going to make that mistake. This is the model that they are using for risk adjustment. They've used it in Medicare Advantage plans for a long, long time. And it's worked for them. Let's get even one more layer deep and look at two providers within this practice who are both seeing a patient with the same primary diagnosis. Okay, so when I've got Dr. 1 and I've got Dr. 2, Dr. 2's patients should be twice as healthy as Dr. 1's. Said another way, Dr. 1's patients are twice as sick as Dr. 2's. Is that true? No, it is not. The difference is in what they are coding. So when we look at what happens when each of these doctors in the same practice, in the same community, each see a patient that walks in the door whose primary diagnosis is hypertension. Here's what happens. For Dr. 1, 1 out of 3 patients, he's coded one of those comorbidities that has an HCC weight associated with it. Dr. 2 only does that 5% of the time. That's the difference. And so we can use the data to provide a little bit of education that says, okay, for this particular practice, when they see a patient with hypertension, what are the most likely comorbid diagnoses that have HCC weight that are associated with it? Well, here are the top 10. So you can see how Dr. 1's patients look sicker than Dr. 2's and why they look that way to the payer. It's because we're not capturing and coding these comorbidities. Right? So there, you can provide education, you can provide training, right? But a key part of it is just knowing the data. Now, what they did, this group, part of the way that they solved this problem is they used this electronic super bill, and what they did was when you click on hypertension, yep, it gives you the diagnosis for hypertension, but it also says, hey, these are some of the comorbidities that we want to capture to try to make it easy for them to remember and to code that so that they get that data out the door and so that they harvest it for their own negotiation with the payers. Because remember, when we zoom back out to the big picture perspective, what are we trying to do? What are we trying to accomplish? CMS wants to measure and pay for quality outcomes and cost effectiveness. And we know that that has to be risk adjusted. So we want to make sure that we are accurately reflecting our patient acuity. Right? That's what we're trying to do, because we want to make sure that value-based reimbursement is going to be done correctly, that when Medicare measures our quality outcomes and our cost effectiveness, that's done correctly, because they're ultimately going to publish that data for patients. We want to make sure that we have the data with our commercial payers so that we can level the playing field when it's contract negotiation time. That's why our diagnosis coding is going to be more important as we move forward than it ever has been before. Right? I know I've gone over a lot of information and I've done it quickly. Let me give you just a couple of possible next steps that you might want to think about. The first is awareness. Share what you learned today. We've recorded the webinar. We'll make that link available to you. Happy to share the PowerPoint slides if any of those are helpful for you as well. But share that with other people on your team. People that need to know about it. Some of you may be light years ahead of me on this. You know, others, you're just starting to learn about this and you need to share some of this information with the rest of your organization so that we can be thinking about that as you move forward. That's one thing. And I'll launch a poll question here in a second where you can ask for different types of follow-up information. Another potential next step is doing some analysis. How are we doing today? How are our doctors doing? Do you know what the average HCC score is for your patients? Does that differ from one doctor to another? Right? We can help you with some of that analysis if that's something that you're interested in. We're happy to do that. It's typically, just to give you an idea, it's about 2.5 cents per patient to do that type of analysis typically. You know, so if you've got a doctor with a 2,000 patient panel, you know, at 2.5 cents, that's about $50, right? So that's not particularly expensive to get a lot of good data and a lot of good feedback. So awareness is important. Analysis is important so that you have a starting point of where you are today. And then action. Where are the opportunities for improvement? Where are there opportunities for retraining? Where are some opportunities for education? How do we start laying the foundation so that we'll be successful in that transition to value-based reimbursement? All right, I'll launch that last poll question. And this one should be multi-select, so you should be able to choose multiple items if you would like multiple feedback items from us. So just choose whatever you'd like. If you'd like a copy of the slides, if you'd like a link to the YouTube recorded version of the webinar from today, if you're interested in talking with us about doing the HCC analysis, we can have somebody follow up with you on that. If you're interested, White Plume is also a software development company. We've got software products that people use either with their providers or with their revenue cycle team to try to help capture some of this. Happy to talk to you about that too. If you don't need anything right now, you can check that one too. So I'll leave that poll question up for just a few more seconds, and I'm going to open it up to Q&A as well. So what I'll do is I'll take a look at these and try to answer as many of them as I can. If you still have Q&A questions that you'd like to send in, feel free to go ahead and do that, and I'll leave that open for us. Okay, thanks for participating in the polls. Hopefully that was fun for you, and we'll make sure that we get you that follow-up information. Okay, yes, if you'd like the recorded version, we'll send that to you. Somebody asked about that. Somebody asked, are the categories for MIPS that we showed, are those for Medicare or do those include Medicaid payments as well? I believe you're talking about these MIPS categories, and that is Medicare only right now. State Medicaid programs may do something going forward, but right now that's Medicare only. If you want the slides, yes, you can download the handouts now if you want to print those out, but if you'd like a copy of the actual PowerPoint file, we will email that to you. Oh, this is a great question. Somebody asked for medical groups, so group practices, is the HCC score, adjusted score, kept per NPI or averaged per group? Great question. So it is not, we've been operating in this world of kind of encounter-centric coding or physician-centric coding, and you need, it's part of it is a mind shift where it's patient-centric now. So it's one of the tricky parts of HCC coding is it is actually all of the patient's diagnoses collected from all providers. So if a patient goes to an urgent care facility, right, they go to the urgent care facility and they've got a new diagnosis, that's added at the patient level. Medicare rolls up all of that data. Now, it would be great if they would share that with us, right, so that we could see all of the diagnoses that a patient has at a patient level, but Medicare does not share that data with providers right now. I'd love for them to do that in the future, but they don't do that right now. So great question on that. Hopefully that answered your question. If not, feel free to come back with a follow-up question. I'll keep an eye out for that. Can you replay this webinar later? Yes. It typically takes me, I don't know, a day, maybe 2 at the most, to get the recording converted and uploaded to YouTube. But for those of you who asked us about that, we will send you the link so that you can watch that at your heart's content. And most of you can probably, if you've got colleagues who are impatient, there is a setting in YouTube where you can speed up the replay. It'll make me sound like a chipmunk, but it'll go much faster if you want to do it that way. Oh, this is a great question. So somebody asked about, for these comorbidities, do you have to code that on every single visit or just once per patient? It's a great question. As far from a technical standpoint, the way that the HCC calculation works, you only need to do that one time in the 12-month period, right? But if you don't code it once every 12 months, it will fall off the calculation for that patient. So the technical answer is no, you do not need to do that on every single visit, but you do need to make sure that it is coded once every 12 months. I have seen some groups who try to capture that at every single encounter because they have a hard time trying to track what falls off and what falls on, kind of when they've done that. Other people have tried to manage that through some rules-based engines that's looking at the historical diagnoses and alerting you, hey, you had type 2 diabetes with polyneuropathy coded 11 months ago. Assuming that they still have that, we need to code that again on this encounter as well. Again, that's probably a bit more nuanced answer than a straightforward yes or no that you were probably hoping for. But I hope that is helpful. So the technical answer is it needs to be coded once every 12 months. So you don't need to do it on every encounter. Some people do it on every encounter to try to make sure that it never falls off. So hopefully that answered your question. Okay, I think that's all the questions that broadly pertain to everyone. If you thought of something else, I'll leave the questions panel up for a few more minutes so that you can ask those questions, and we'll follow up with you offline on those. If there was any other follow-up information that you wanted that you did not put in the poll question, just put that in the questions panel, and I'll make sure that we follow up with you on that as well. We are done 3 minutes early, so thanks again for your time this morning. I hope this was helpful for you, and please, if you don't mind, take 30 seconds and answer that webinar survey. It's just 3 questions, and it helps me make this better for everyone else going forward. I greatly appreciate it. Hope you have a great rest of your Tuesday. Bye-bye.